Conjunctivitis is, hello,
Yes, yes, sir.
can you hear me, please?
Yes, sir.
Okay, so conjunctivitis is basically inflammation of the conjunctiva. So I've explained earlier what the conjunctiva is all about. Please move to the next slide. Good. So we remind ourselves again, you know, we talked about this earlier in the pterygium topic. So
Yes.
here again is the conjunctiva, a transparent mucous membrane that lines the inner surface of the eyelid and the anterior surface of the globe, terminating at the skull. I've explained all of this. So next slide, please. There's a diagram, good. So it's like cutting the eye, a bit the head vertically. I don't know if you will understand this picture. Hello?
No, sir.
Hello?
Yes, sir. Hello, sir.
Do you understand the orientation of this picture before I continue?
Yes. It says it's like
Like
slicing. It's like cutting the person
sliding the
vertically.
head vertically. Do you get?
Yes.
Okay, good. So, Isaac, please put it at the inner lining of the lid, that green part, the green part, green part. Good, good. So we remind ourselves again, conjunctiva is divided basically into three parts: the palpebral conjunctiva, the bulbar conjunctiva, and the phoenicial conjunctiva. So that green part, like I explained earlier in the other lecture, is what we call the tarsal or the palpebral conjunctiva. It lines the inner lining of the eyelid. Now, it's still continuous. When it gets to that junction of the red, that red part, that's the phoenicial conjunctiva I was trying to explain that time. So from the lid, it finishes, then now comes to the eyeball. So that part, that fold is called the phoenicial conjunctiva. Then that yellow part, you know, is the bulbar conjunctiva. That's lining the eyeball now. But of course, it's not covering the cornea. So that blue part is the cornea. Conjunctiva does not cover the cornea. It stops at the limbus, what we call the corneoscleral limbus, the junction between the sclera, which is the whitish part of the eye, and the cornea, the clear part of the eye. So that is the basic anatomy of conjunctiva. And we stated earlier that it's supplied, the bulbar conjunctiva is supplied by the anterior ciliary artery, the palpebral by the marginal arcades artery, and all of that. So next slide, please. Okay, so next slide, we've explained this. Next slide. Good. So conjunctivitis. Sorry, I was rushing this slide. There was a slide that should have come before this one. So basically, conjunctivitis is divided broadly into two: non-infective infective conjunctivitis and non-infective conjunctivitis. So as the name implies, infective, infectious. Do you understand? So you have bacterial conjunctivitis, viral conjunctivitis, and so on. Then you have the non-infective, like allergic conjunctivitis. So we'll briefly talk about bacterial conjunctivitis, viral conjunctivitis, then we'll talk about the allergies, and we'll end it there. So bacterial conjunctivitis, simply, okay, there's the acute bacterial conjunctivitis, which is common and usually self-limiting condition, and is caused by direct contact with infected secretions, any secretions, either tears, you know, and all of that. Contact to the eye. Let's say someone has conjunctivitis now, and maybe you shake the person's hand, you know, and before you know it, maybe your eye is itching you, you now attempt to, you know, rub your eye, and that's it. You've directly inoculated your eye, and you have bacterial conjunctivitis. So many chance of contacting bacterial conjunctivitis. And there are a lot of organisms. The few are mentioned here: Streptococcus pneumoniae, Staph aureus, Haemophilus influenza, Moraxella catarrhalis, and even Neisseria gonorrhea and Neisseria meningitidis. All of these cause acute bacterial conjunctivitis. Next slide, please. So basically, the symptoms are acute onset of redness of the eyes, grittiness, burning sensation, and discharge. The discharge can be purulent, can be mucopurulent depending on the causative organism. Like Neisseria gonorrhea. Neisseria gonorrhea causes what we call, purulent discharge, very plenty discharge like that and all that. So it actually depends on the organism, the type of discharge that occurs. And the involvement is usually bilateral, although one eye may start first and maybe few hours and to days later, you may have the fellow eye getting involved. And on waking up, the eyelids are frequently stuck together and may be difficult to open. Next slide, please. So the signs are variable and depend on the severity of the infection. Sometimes, most of the time, the vision is usually normal. It doesn't really cause poor vision. The only time it may cause poor vision is if the discharge is much and is gumming the eyelids together, thereby closing the eyes. Of course, at that instant, the vision will be poor. Otherwise, normally the vision is good. And there may be eyelid edema, that's swelling of the eyelid, and erythema, like reddish discoloration of the eyelid. There may be what we call conjunctival injection. That's like redness of the conjunctiva. And the discharge can be initially watery. It can mimic viral conjunctivitis. In viral conjunctivitis, you have a watery, like water, excessive tears coming out. Unlike in bacterial conjunctivitis, that the discharge is milkish in color and thicker than the viral distance. There may be what we call superficial corneal punctate epithelial erosion, basically an association of the corneal erosions, cornea getting eroded. Cornea has about 5 layers: the epithelium, the Bowman's membrane, stroma, deciment membrane, and the endothelium. So if there is epithelial erosion, punctate, like pinpoint erosions on the cornea, it's associated with conjunctivitis too. What happened? Okweko? Okay. Put it in slideshow. Hello, Okweko?
Sorry, I'm coming.
Yes, sir. We can hear you, sir, but the
signs. So these are the symptoms, some of the pictures that depict the symptoms and the signs. Like you can see conjunctival hyperemia on that single picture of the conjunctiva. So this is what we call injection of the conjunctiva. Is injected, red, or we call it hyperemic conjunctiva. So then you can see lid edema too. swelling of the eyelid around, this thing. Then you have what we call chemosis. Chemosis, you know, chemosis is the swelling of the conjunctiva. We call it chemosis. So that's another milder form down there. So that is it. So next slide, please. Okay, so, well, in as much as you can make diagnosis clinically of conjunctiva, you can sometimes, when you are not so sure, especially, I told you the type of discharge somehow can, if it's very watery like water or tears, is more of viral origin, if it's mucoid, purulent, bacteria. So, but if it's neither here nor there, you can investigate, you can do what we call conjunctival swab, MCS. You take, swab from the conjunctiva and even scraping of the conjunctiva for gram staining and all of that. You can do culture sensitivity too. You can, well, where you have the facility, do polymer PCR for the patient. Next slide, please. So these are what, this tiny, that inverted eyelid, there are some tiny pinpoint, this thing on the palpebral conjunctiva or the tarsal conjunctiva. You can see the conjunctiva is red, so it's hyperemic. Then those tiny things are what we call follicles. They are as a result of the inflammation going on. Then this other picture still depicts conjunctivitis. Yeah, next slide, please. So basically the treatment, even without treatment, about 60% of acute bacterial conjunctivitis resolve within 5 days without treatment. But then with treatment, you fasting, as in you increase the healing process. So you can use topical antibiotics, usually 4 times daily for up to a week. But sometimes it can be intense. You can even use it hourly or 2 hourly for, let's say, the first 48 hours, then you can now reduce it to 4 times a day thereafter. So there are a lot of options: chloramphenicol antibiotics, aminoglycosides like gentamicin, neomycin, tobramycin, all in form of topical eye drops. You have the quinolones, that's the ciprofloxacin, ofloxacin, levofloxacin, and all the floxacins. Then you have the macrolides, erythromycin, azithromycin, and all of that. So you have a lot of options when it comes to bacterial conjunctivitis. Next, please. So there are other things you can do apart from the use of topical antibiotics. You can do irrigation to remove excessive discharge, which may be useful in hyperpurulent cases, like I explained there earlier. For example, in Neisseria gonorrhea, cause of bacterial conjunctivitis is really purulent. You keep cleaning and it keeps producing discharge and all of that. So irrigation can help. For those wearing contact lenses, it should be discontinued until at least 48 hours after resolution, complete resolution of the symptoms. So because it causes a lot of effect on the cornea. So you can reduce the risk of transmission by hand washing and avoidance of towel sharing, handshaking, and all of that, because all of these things can serve as fomites. Handkerchief that you use, towel, and all of that are fomites. They are vehicles for transmission of infection. So you have to reduce the transmission by avoiding towel sharing and washing of hands and all of that. Then you review the patient thereafter. But usually the prognosis is very good and all that. Next slide, please. So we talk about another type of infective conjunctivitis, which is the viral conjunctivitis. It's a common external ocular infection, particularly the adenovirus in 90% of cases. And it may be sporadic or it may occur in epidemics in environments like workplaces, hospitals, schools, swimming pools. You know, in swimming pool, a lot of people enter, you don't know what they have, you know, you can get infection from there. Likewise in school and even in the hospital setting, nosocomial infections and all that. So next slide, please. So the spread of this highly contagious infection is facilitated by ability of the viral particles to survive on dry surfaces for weeks. Yes, you know, and that's how the viruses, you know, act. So they can stay, you know, with that their inside that their shell for weeks and can still transmit an infection. And the infection can be via formats like we mentioned earlier, ocular secretions and all that. Next slide. So the presentation, symptoms, like we said earlier, redness of the eye. Go to symptoms, redness of the eye, watering, you know, as excessive discharge, watery discharge, irritations, itching, mild photophobia. Photophobia is when there's bright light shown on your eye, you feel very uncomfortable. So that's photophobia. And it may still infect the fellow eye about a day or two after the onset of the other eye. So that's the typical presentation. Next slide, please. So the signs are pretty much like we said before, eyelid edema, which may range from negligible to severe. Lymphadenopathy is common. Like there are a lot of lymph nodes, you know. You have the submandibular, the submental, the preauricular, the postauricular, the occipital, and all of that, even the cervical lymph nodes. So particularly the preauricular lymph nodes are affected. Also the submandibular too, you know, are involved basically when it comes to eye conditions like this. So you can have conjunctival hyperemia. I've explained what hyperemia is before, the follicles I've shown you before. So you can have a lot of, so in viral conjunctivitis, you have the follicles more, you know, and conjunctival hyperemia more. So you can have chemosis. I've explained chemosis, that's swelling of the conjunctiva and all that. So next slide. So investigation, like we said earlier, you know, usually viral infections generally are self-limiting, you know, so even without treatment, they run their course and go and all of that, but you still want to be very sure that this, though from the characteristics of the symptoms and signs, you can treat, you can have high index of suspicion and treat. However, you can equally do investigations like PCR, viral culture, and all of that. But these things are not really in our settings, so we still manage them clinically. Next slide. So treatment, usually there's a spontaneous resolution of viral infection within 2 to 3 weeks. So no specific treatment is typically necessary. And there is no antiviral agent we use. So like I said earlier, it's a self-limiting. So basically, most of the treatment you give to viral conjunctivitis, you don't give antivirals. You treat the symptoms. Oh, there's inflammation, redness. You give NSAIDs. You know, you can give tear substitutes. You can give lubricants, all to reduce the symptoms until the viral infection runs its course and goes. So basically, you don't usually give a specific drug for the viral infection. like we said earlier, you can reduce transmission by meticulous hand washing, avoiding eye rubbing, towel sharing, and all of that. Next slide, please. So the other measures you can take: discontinuation of contact lens, like I mentioned earlier, use of artificial tears, cold or warm compress for symptomatic relief, topical antihistamines if you're having itching. Then you can give topical antibiotics. Yes, you know, viral disease will reduce the immunity, so there may be risk of secondary bacterial infection, so you can give antibiotics. Next slide. So we come to the non-infective conjunctivitis, and particularly the allergic conjunctivitis. There may be even what we call chemical conjunctivitis. If there's toxic substance in the eye, it may cause what we call chemical conjunctivitis, because like we mentioned earlier, conjunctivitis is basically inflammation of the conjunctiva. So allergy, chemical, they're all part of the non-infective conjunctivitis. So allergic conjunctivitis, atopy generally is a genetically determined predisposition to hypersensitivity reaction upon exposure to specific environmental agents, antigens rather. And the clinical manifestation can range from allergic conjunctivitis, hay fever, asthma, eczema, and all of that. So allergic conjunctivitis is actually a type 1, though a type 1 immediate hypersensitivity reaction, which is mediated by degranulation of the mast cells in response to the action of IgE. I'm sure we are familiar with what type 1 is all about, so there's no need overemphasizing it. Next slide, please. So there's the acute allergic conjunctivitis, which is a common condition by acute conjunctival reaction to an environmental antigen, usually pollens, and usually seen in younger children after playing outside in spring or summer. And there's acute itching, watering, and chemosis, which is the swelling of the conjunctiva, like I mentioned earlier. And it runs its course and go. Treatment is usually not required, and the conjunctival swelling settles within hours. Cold compress can be used, and single drop of adrenaline may reduce extreme chemosis. Next slide. So that acute allergic conjunctivitis is a type of allergic conjunctivitis, while seasonal and perennial allergic conjunctivitis are other types too of allergic conjunctivitis. So they're actually subacute, while the other one is acute allergic conjunctivitis. So what was the difference between these two in terms of how the duration, maybe how they typically, what time of the year they play? So in the seasonal one, as the name implies, seasonal. So in the season, the spring and the summer, they are more common. And the allergens are usually the trees, the pollen grains, the grass pollens, and all of that. While the perennial is always there throughout the year. And it's actually worse in the autumn when exposure to house dust mites, animals, is greatest. So basically it's about, you know, what's it called, the season. Perennial is always there, seasonal is seasonal. So next slide. So diagnosis, symptoms: transient, acute, or subacute attacks of redness, watering, itching. So in allergy, you have more of itching. Unlike in the infective, you may have mild itching, but in allergy, you have itching. So that's the hallmark. There will be tearing too. And because you are itching, you rub your eyes. And when you rub your eyes, it causes redness of the eyes. So redness, watering, itching. And in some people, the complete atopy, maybe sneezing and nasal discharge, and even asthmatic attack. So signs: division is usually normal. There's conjunctival hyperemia, that's redness of the conjunctiva, with variable chemosis, that's swelling of the conjunctiva, and lid edema, swelling. So investigation generally not performed, although conjunctival scraping can be done, and skin test for particular allergen is, though, can be done, but is usually not required. So treatments, next slide. So use of artificial tears for mild symptoms, then specifically mast cell stabilizers. We told you about degranulation of the mast cells before. So to prevent the degranulation, you use these agents, sodium chromoglycate, nedochromoline, chromyl, and sodium, and all of that to reduce the type 1 hypersensitivity reaction. Then you can use short-acting, this thing, the antihistamines, emedastin, epinastin, and all of that for symptomatic exacerbation. Then you can do dual combinations, olopatadine, ketotifen, more of like mast cell stabilizer and the antihistamine. You can also give very mild non-steroidal anti-inflammatory medication like diclofenac too, even mild steroids. And there is room for oral antihistamines to Piriton, loratadine, and all of that. Next slide. Oh, thank you.
So if there's question, please kindly ask before we call it off today.